Hey everyone, this is the Nips and Sips podcast show featuring me. I'm Dr. Jeremy Boyd and my usual partner in crime over there, Dr. Brandon Cruz. Today we're going to be talking a little bit more business in the regards of a traditional PT practice versus a direct access practice. So we kind of dabble a little bit in both. So we figured we'd talk about it. But before we get into it, Brandon, how's it going?
Well, Jer, it's early Thursday. I had a late flight in last night, so we're drinking coffee here again. I have my Sam's number 3 cup, which if you ever go to Denver, that is the spot to go for basically breakfast, lunch, and dinner.
What's the
But
name of it?
Sam's number 3.
Oh, I like
It's
it. Number
actually it
three.
was on Diners, Drive-ins, and Dives, I believe.
Ah.
But while I was out doing my fellowship training at Regis, Raf and I would go there basically every day. So we made sure we'd get up early and go there for some food before class started. We even went there for dinner a couple times. So great place. If you're ever out in downtown Denver, check out Sam's number 3.
Kind of just want to go to Denver just to try it.
Yeah,
Sounds like good.
definitely
If you
worth
go
it.
to someplace multiple times in one trip, that's legit.
Multiple times in a day. I went there for breakfast and dinner in the same
Wow,
day.
that's damn good food then. Because I don't know if I've ever
They
really
they
done
have a
that.
Trailblazer. I believe Raf and I both ordered the Trailblazer like numerous times.
What?
Which is a breakfast dish. I don't know. It's like eggs smothered in some type of chili
Oh, baby,
mess. I don't know. It's just goodness coming all the way down.
goodness. There we go. Um, no, we got to say not as entertaining a story, but I got this cute ass dog dad cup from Alyssa's cousin Melissa and CT. Thanks for that. He doesn't
That's
really
cute.
look like this, but it's
No,
all
no. That you and Jeremy looks a little pale on that
a little
photo as well.
pale, a little bit more hair, a lot less gray hairs on this one. So
Yeah.
I'll take it. I'll take it. But all right. Well, and I guess other news. Congrats on your grand opening. I think
Thank
that
you. Yeah, that was a week ago. Wow. I feel like so much has happened from that point till right now.
yeah,
Literally, it was 1 week ago. Yeah.
it looked good. I mean, the photography of you cutting the ribbon there, it looked like professional level, like you've been doing this.
Yeah. Well, actually, while we're on it, got a big shout out to Darren, who was one of our former interns. You met him while you were doing
Yeah.
your mentorship hours. He's now licensed, graduated, works in Brooklyn now, but his passion and I guess kind of side hustle is he's a wizard with the camera. So big shout out to Darren for coming out and supporting us and taking awesome photos, capturing the moment. We had a great turnout, better than I could have ever imagined. Whole staff was great and supportive. It was just awesome, awesome night.
That's awesome. Well, congrats, many blessings to getting off the ground. Sounds like you're off to a great start. But yeah, speaking of practices and businesses, well, let's talk about our referral sources. I guess what I referenced in before about a traditional PT or PT referral is your classic, getting a referral from a physician. So a patient is in pain for anything neuromusculoskeletal. They go to they wait a while, usually, about 2-3 weeks. They suffer for a little while. Then they go to their primary. Maybe some are wise enough or maybe not wise enough, but they go to their ortho or somebody first. But then if they go from primary, they go to the specialist after now a month has passed, maybe even 2 months, then maybe implement things such as injections or imaging. And then if
Yeah.
we're lucky, they potentially refer off to us. And that's probably, I don't know, what would you say, Brandon, on average? I would say it's probably closer to 2 months, maybe
Yeah,
three
two,
at
three
times,
months out.
especially
Yeah.
shoulder. I don't know why shoulder is usually like closer to 3 months.
Shoulder and low back pain.
Mm-hmm.
Like people just live with it. And then they come in sideways.
Yep.
Oh, I thought it was gonna go away.
Yeah. Like, yeah.
Lack of education out there. From the physician standpoint, And obviously we've read articles that most low back pain will spontaneously go away in 14 days. So maybe that factors into some of the decision making, right? How many times have we heard the doctor's advice? Just here, take some NSAIDs and rest for 2 weeks, right? We've all heard that, and it's just like, I don't know. I get frustrated because it's like you went to school for all that time, and that's what your advice is, just to not do said activity. Especially knowing that there's PT, and granted, not all PT is good PT. A lot of, still using modalities, still ice stim, heat, the UBE. I don't know, just a lot of garbage out there. Which, if you're a therapist, listen to this, and you probably are, because I don't know of too many other people who are listening to this.
So
If I said that and you're thinking that's you, it's okay, but it's time to reflect and begin to search to change your practice patterns.
mhm. Yeah,
So
and that's it. That, let's face it, those outcomes. I mean, treating that way doesn't help our outcomes. How many people do we get?
help our profession.
Huh? Doesn't help. Yeah,
Doesn't help our
exactly.
profession.
You see, and they don't get better, and people view that as physical therapy, and then they go back to the orthos or primaries, whatever it may be, and they're like, well, they didn't get better with PT. And is it PT's fault, or that's not real PT in my opinion? Real PT is active, it's movement, I should say, I said before, is you should sweat in PT regardless of what kind of setting or realm it is. Acute care, they're grinding, they're fresh off of a total knee replacement, so them getting up and out of a chair a couple times should make them sweat. Outpatient orthopedics, you should do stuff that challenges people. We saw Chris Carroll on this show in PT Reframe. He, in the neuro setting, he challenges his patients, so it should be that type of active. And then doing more higher
The
level
stuff that they tell you not to do in school, and he's
yeah.
he's doing it, and obviously he's safe about it, but he's elevated their blood pressure and their heart rate,
Mhm.
which a lot of times is deemed a contraindication. But
Mhm.
I think some of that stuff's outdated, and we need to understand how the human body works.
Something you just brought up there is kind of go off on a tangent, is you said things that they told us not to do in school. How much of what kind of that fear mongering in school kind of dictates our future clinical patterns and that sort of stuff, of
Oh,
like, oh, don't do this, or we have a spinal cord injury, they're fragile or whatever, or we have a cervical manipulation, you can kill them, don't do that, or people can have a heart attack in the middle of your session and that sort of stuff. How much that kind of potentially dictates how much we push our patients in a good way. Just I don't know if you have any thoughts about that. Because
no, great question. I mean, these are buddy trails. This is what it's about. You come to one of our courses, this is what happens. You come to our mentorships, this is what happens. I think that's how you grow, instead of just following a blueprint, which I think a lot of people want, or maybe conditioned to have that blueprint. I mean, we have it in our courses when we're teaching manipulation. It's like, oh, it's not indicated. Well, what does that mean? When is it not indicated? Because my list of not being indicated is like this big.
Mhm.
Meanwhile, you go to a textbook and it's this big.
Mhm.
And you have to understand the difference between absolute and relative. You have to understand what that patient's presenting in front of you like. You have to understand your skill set, your ability to I guess modify situations or positions to make something successful for a patient. I've manipulated a 67-year-old lady with osteoporosis and a 47-degree spinal curvature. The only thing that gives her relief,
Mhm.
and it works. But guess what? She has osteoporosis. Don't manipulate her. She's older. Don't manipulate her. Right? There's every reason not to manipulate her
Mhm.
via textbook, instead of just using clinical decision making around it. So not just going and defaulting to oh, I learned this in undergrad, or I learned this in grad school. I think that's another big problem. I see a lot of clinicians out there, 6, 7, 8 years out. Oh, this is what we were taught in school.
Mm.
Like, if that's your rationale, this is what we were taught in school. Like, you have not progressed at all as a clinician. And we're going off tangent here, but this will loop back to direct access versus traditional referral. I guarantee you when we get to that point. I will make it fit.
No,
What about you?
it's awesome. We'll make it work. We'll speak it into existence. That's what it is. But no, I think that's some great points. Or the opposite was like school didn't teach me that. That's another one. I hear that way too often. I'm like, school can't teach you everything, and it's not their job to teach you everything. It's supposed to be a kickstart, ignite the flame a little bit to further your knowledge and education for you to do that. It's lifelong learning, not I'm done with PT school learning. So, this is a completely unrelated topic. If the missus listens to this, but why the missus and I work together is because of lifelong learning. So at the time, she doesn't really like this story very much. And now we're really going down a bunny trail. But so I was in residency, and I'd go, this is after Brandon graduated. And so I was going, the next cohort wasn't as nearly as spunky and fun and active as much. So I'd go in, Tinder was a thing, and I would, swipe away. And at that time, I swiped my wife now, Alyssa, go Alyssa, and a PT student. Hopefully she's not listening to this, but so I had a coffee date with her, and then I had a dinner date or drinks date with Alyssa same day. It might have been the second date of each, or second date for the student or wherever. She was like a last year student, but one of the things was, we talked about things, and I was right down the residency model. I'm already thinking like big picture, further down, fellowship, whatever it may be. And in conversation, this student was said, she's like, oh no, once I'm done with school, I'm done. It's like, I'm just gonna go and work. And that was such a turnoff for me. That was just like, yeah, I don't know about this one. Obviously, seeing Alyssa a couple hours later, she blew her out of the water, but that was a nail in the coffin for this one. So yeah, sorry, that was definitely a bunny trail that most people in here, but kudos to Alyssa. She always want to see the world, experience much of things, keep learning in life. So that's why
keep living. Yeah. I think you guys are good. What are you, like 3 years in? So
if marriage, yeah, we're good.
3 years in a marriage, yeah. So
pretty locked in.
No, but congratulations to you and Alyssa. But no, it's true. I mean, too many people are just kind of wait to the end. But I think that tying this back into our main point, direct access versus not, and you and I, especially you starting after me, and you're like, what did you do and what didn't you do, and yada yada. Now part of this was the mission, like pursue PT, pursues to seek out, right? To seek out physical therapy as your first alternative. That and some more was, the basis, my mission in starting. I wanted us to be, the primary go-to. So initially, a lot of my, for the first 4 or 5 years, 95% direct access, word of mouth. Oh, he does a good job, go to him. And part of that is my ability to think outside the box. Obviously, I've been taught that. I was not that clinician years ago, but it's something I progressed to over time, where it's like, all right, well, let's try this. All right, well, you've been, to 2 or 3 different of the spots. They did X, Y, and Z. Let's not do those. Let's not go down. And I'm not reinventing the wheel. Let's not do that stuff, or let's do less of that stuff. And let's try maybe treating some other regions, or let's take a different perspective, or maybe, what you've been told you have isn't as bad as you thought. So maybe we're just educating somebody. So, that was, able to, my obviously residency and fellowship training gave me that confidence to be able to do that. Give me the confidence to differentially diagnose at an accurate level, whatever differential diagnosis means, because we're always saying we don't even treat the diagnosis, we're treating impairments anyway, right? So utilizing test, retest, identify red flags, identify yellow flags or orange flags. What are red flags that could be modifiable, maybe aren't true red flags, or maybe the person just has to live with red flags because of they don't want surgery, or they don't, or they're just old, too old to want to be a proper candidate for surgery and things like that. So that's where direct access really played a role. Now, obviously, depending on what state you're in, your direct access laws may vary and restrict you a little bit. But here in New Jersey, we get 30 days, where they have to show improvement. So as long as they're showing improvement, you can kind of continue. So that, direct access / word of mouth is where we really began a foothold. And now that we're growing, we have a marketer and stuff like that, and we're now able to get, some referrals from doctors because, they've heard over time that we're good. Or you get one patient that goes back to the doctor and says, hey, this place was awesome, and they become your raving fans type of deal. Now we're getting more traditional referrals and things like that. But going out and consistently buying doctors lunch or taking them out for dinners was something I did not want to do. Now maybe we bring them coffee or buy, a small lunch, but it's not the focus like like a lot of practices do or used to do. I don't even know what they do anymore. So that's good. I'll talk about, the digital media side of things in a little bit and how we market with that. But I know you had a similar story if you want to share yours, Jer.
Yeah. Just to build off, I thought you brought up a great point. And then I'll kind of talk about my story. It was when you're starting up and, people been to 2, 3 other places and they're doing all these other things. Just for our listeners, viewers, whoever's out there, I think that's a good thing to always ask. Sometimes I have students who just kind of blow past the, hey, did you have physical therapy before or anything like that? Or what were you doing? I think it's always a good thing to get that viewpoint so that you're not doing the exact same stuff. You're looking outside the box. And for the, obviously we're biased in the application of manual therapy. But more often than not, the ones that are in chronic pain and been to 2, 3, 4 places, they did exercises. It's part of the standard. I would say if one thing unites all physical therapy places all throughout the world is whether it's a mill or a more one-on-one shop, it's usually some exercise and some movement. And some places it's less intense. But ask about these sort of things so you're again not repeating, you're looking outside the box, you're doing more of a multimodal approach. So I thought that was a good point. But to kind of go back, me personally, I was teaching at a school, Rowan, right where my practice is, and told the students my day-to-day job as a PT, and a couple students were saying that one, it didn't work for them. A couple said they actually got worse, which should never be the case. If you're making people worse in therapy, either you negligently, I don't know if that's even a word, missed some serious flags, or you're really not listening to the patient or not doing enough to try and modulate things. You're leaving them by themselves, their own devices to kind of screw up in a sense. So I've had some people that may have not made much progress, and something else was happening, but very, very, very few people should get worse. Should almost not happen at all. But that was my motivation to start up my kind of my practice in that town. Was I heard that and I was just like, that shouldn't be the case. And then they threw in the fact that the a couple places right around the block, they're doing the same exercises as grandma and grandpa. So yeah, that's fine if you're doing same things as grandma and grandpa, but it should be deadlifts and squats, and it should be intense. It shouldn't be just lateral trunk rotations and single knees to chest for everybody who has a lower extremity issue, regardless of what. So I want to be that individual that kind of change how things are done in that area. I want to talking to some of these kids, and some of them, in college were having 2, 3 surgeries deep. I was like, that shouldn't be the case. They should have different options here. And it was already starting to hear, and we were just talking about that this last night with my students. Was we have a couple young people, and I'd say there's 4 or 5 of them that are my caseload alone that already have this poor thought virus fixation on a medical diagnosis, whether it's a labral tear, herniated disc is another one, um, maybe 2 herniated discs, and I'm forgetting the other one right now off the top of my head. But and they're like high school to maybe like freshmen in college. Then they already have this, and it's sad that these kids are already getting planted with this negative kind of seed that they're going to carry for the rest of their lives. And I'm educating them and that sort of stuff, but it's tough when that's already, I'm gonna have to go and dig deep into the roots to unplant this seed and try to plant more positive ones. So I wanted to be that person who's like, if I can get them first, I can modulate things, I can get them moving. They're never going to have those seeds to begin with. I'm never going to have to spend so much time and effort, explain posters and all these sort of things. I can just plant a good seed and say, anytime something sort of happens, try and remain active, text, call me. We can always help you out. If you move to the other side of the country, I'll find a place for you that's, like-minded. So that's why I really, that was kind of my vision with things. I just had to, we talk about PT burnout on this show and everything like that. One thing that's especially passionate for me is being that detective. You mentioned differential diagnosing. I mean, nothing's more fun for me is like getting a patient there, having nothing to build off of, and the gears are starting to kind of go before the patient even walks in. And then each, like, I always kind of view as the part in The Hangover where they're going down the escalator into the casino, and the dude's
Oh
got all
yeah,
the
yeah.
numbers.
Zach Galifianakis has the numbers.
So
Yeah.
like that's fun for me. That's a joy for me. And even when I'm, luckily at this stage, I always say, like, maybe start off your career and your top hypothesis is 80%, 70% right. And now it's getting to a point where, it's 98, 99% or maybe 95, whatever it may be. But even when I'm wrong, like, learning from what I missed or anything like that is still fun. Not, obviously not for the patients. Obviously I'd like to figure out in the, first session or whatever it may be, but that's fun for me. And that keeps me passionate about things. That keeps what I hear, like the dread of evals for a lot of people and the paperwork.
Mhm.
They're missing out on the fun of the eval, the discovery, the figuring that sort of stuff out. So yeah, there's, I don't know if there's any way to make it fun to type up an evaluation, but at least you can get fun figuring out what the heck's going on. So you get a lot of that in direct access, or even people who are non-direct access. We always mention in our shows, our shows our courses, that really everyone's a direct access patient. I get a ton of ACLs now, and that's something, my good reputation and everything Brandon talked about before kind of started this thing that we became a ACL kind of clinic. But even all of them have their own unique thing that I have to differentially diagnose. I had someone with a deep peroneal nerve entrapment or irritation or loss of sensation. Have another one that she had some chronic hamstring stuff that we were doing, actually cervical manipulations, helped her retest on that. So doing that keeps things lively for me. So yeah, that's kind of my motivation. And we more of a split now, again, because we built up such a great reputation within the community. But that's still something that we want to do. We want to be that first provider, but working in synchrony with the local medical people. Now I pick who the surgeons that I think are super awesome and everything like that.
Mhm.
And we all work together, and having the best blend of both worlds. But
Yeah, and I think, breaking away from the traditional referral, getting referrals from other people in the community, this, I guess, in the long run, or it still goes on direct access, but instead of maybe going directly to physicians, can you go to a yoga instructor? Can you go to a CrossFit gym? Can you go to a personal trainer at a standardized gym? Go do races. Market other ways. You do a great job of this. We don't. you have your weekly or almost daily posts, either showing what you're doing in the clinic or showing a technique that helps said injury or diagnosis, which is great. On my end, I do more advertising to direct to consumers. We have, especially with direct access, you can market straight to your consumer now. You can set an ad up on Instagram or Facebook and things like that. And, I'm still refining that aspect of marketing. But what I did in 2020 during our shutdown was I learned that side of things. I learned how to create a landing page. I learned how to create a website. I learned how to understand marketing at a deeper level. So now I can go market, people in my area of a 5 or 10 mile radius. And, it definitely has helped. We get more traffic, we get more calls when I run those versus not. Those are more general. I want to become more specific, but that is a realm as well. It's something we do with our courses. We market that. We've 4x this year over last year from that, and it's directly because we're email marketing, ad marketing, things like that. So if you are a business owner or if you have a side hustle, I mean, there are more than one ways to go out and get patients than feeling like you need to go into a hospital or physician practice and feel like you get shut down. They don't want to see you, et cetera, et cetera. So there's more than one ways. Today, things are honestly, they're so, I don't want to say easy, but they're a lot easier than they used to be. There's still challenges in everything. Things are going to be hard. It's just what avenue of hard you want to get to. But things are such more mainstream. With marketing online now, though, everyone markets online or puts their 2 cents in. So now you have to cut through the noise too. So there's an uphill battle in terms of that. I just saw an ad today of like someone like, oh, your piriformis is stuck. We have to mash it. And they were doing some real, I'm like, I don't believe in it, but whatever. But, good for that person. They're putting out content. They're putting out an ad. You might have an ad that's different, has a different message. So which one's the person going to choose now? So there's always competition, which is good. It's healthy. It's just there's more than one way, and there's going to be challenges no matter what avenue you choose. Mm-hmm. Ultimately, I think it's especially as you're growing, and everyone has their own definition of growth and size they want to get to, but you want to hit things as in multiple realms or different avenues as possible. You don't want to rely on just one stream. Mm-hmm. So, at some point going to physicians, developing that relationship, going to schools, college or high school, going to ATs, gyms, coaches, whatever the case may be, is probably the best thing to do in a long term. It's hard to do all at once in the beginning. So, choose a vertical and go with it, and then, expand from there. I think, growing, I definitely did that probably wrong, where I tried to do too many things and, was okay at all of them, but didn't knock one out the park. But look at Jeff Bezos. He chose one vertical. I'm going to sell books. He did that for like 15, 20 years. And now he sells whatever the fuck he wants to sell on Amazon. So
they have their own healthcare system now.
Yeah. Yeah. So, choose one or two verticals, rock with it, and then you can expand and grow from there.
Yeah, a good book is, the one thing, focusing on that one thing, mastering that, and then you can, go off of like bunny trails, as we would say. So, that's a tough thing, especially for those people that are starting off. I was in the same boat where it's just like, oh, I got, shadow and be with physicians, but I gotta do a post, and I sucked at post. So it'd be an hour to make a damn post. Then I gotta go meet out the coaches and personal trainers and respond to every message and everything like that. But if you're, consistency is key and that sort of stuff. I know like certain things for my old company used to do things like where we'd shadow with surgeons and doctors and that sort of stuff, and it would never. They always had a constant cycle, but it wasn't until a therapist was there regularly there that they build that trust that they would send me off. And that was sometimes, a problem of mine is I would get like jaded. I was like, oh, met up with this person, didn't get anything for whatever it may be. And then I'd kind of end that project and that sort of stuff, and probably really should have stuck with it. Cause, a lot of times you don't see the the fruits you kind of sell.
With your labor, don't
Yeah, fruits of
come
your labor until
instantaneously.
two,
Yeah.
3 years ago. There's a guy I just evaluated 2 days ago or 3 days ago. Um, and I met him probably within the first couple months, maybe before the first year. He owned a gym in our town, sold off the gym, is doing some other stuff. Um, and I never would think he would ever came in or anything like that. But we made that connection 3 years ago. And he's like, "Oh, I've been telling people about you since." And I was like, "I never even worked on you until now." So
Yeah.
keep that in mind. Of don't give up on those sort of things, and keep on tabs on people. But yeah, it takes sometimes a couple of years, and you got to think, I'm in it for the long haul. This is hopefully something that I'm doing for 10, or my business is going to be here for 10, 20, 30, 40, 50 years.
Yeah.
And even as a clinician as well, if it's not a particular, I own this business, think of it as your private little niche. I had an opportunity to work with someone who ended up doing a dance fellowship, Dr. Amanda. So she's one of the few fellowship trained in dance therapy. But before she did that, she did a residency at Temple.
Mhm.
And she was super passionate about dance, and she was like building things up. She got in with a dance studio and like convinced them to do like a kind of exercise class for like some of the adults and that sort of stuff with some dance components, and was like building that up. And just we made that one of her goals for the year, is get, I don't know, maybe 3 dance evals for a quarter or something like that. And she's working, she's typing up stuff on it, and nothing came. And you can see how like heartbroken she was. And then she went on maternity leave, and so I took over a caseload, and sure as shit, uh we got like 3 dance evals. And of course I don't know too much about dance, and I'm like
Yeah.
texting her, I'm like, I'm getting all these dance evals.
What do I
And
do? Yeah.
yeah, so, and she's like, of course that would happen. But she I was like, this is amazing, it finally came through to fruition here. And when I left and everything like that, it kept growing. I'm pretty sure where we worked at BSR, they even put like a dance bar in just for her. So it was cool.
Nice.
Now she's developed into being a dance fellowship trained PT. So it's really
Awesome.
cool. So just stick with it. That's it. Consistency, everybody.
Yep. All right. I think
Mhm.
I mean we could probably go on a little more, but let's cut that short today. We both got some stuff to do, but hopefully that helped give some perspective of, if you're thinking about going out on your own, or you've started, or you have a side hustle of, hopefully what different avenues you can go down into. We say it in our courses, we say it now, it's consistency, which isn't always easy, probably trying to master one or two things before you go on to the next thing. Don't get discouraged easily. It's definitely not for the faint of hearts, or whatever the saying is there. If you're having trouble, reach out to people. Reach out to people who are where you want to be, or have been through what you've gone through. I'd say, I think that's, you know, something I probably could have done better, is reach out to more business owners, maybe take more business courses earlier on. I've taken a lot over the past few years, but early on, definitely could have done better on that, instead of trying to do things yourselves.
Yeah.
Which is kind of why you get into business to begin with, as a PT, is you want to do it your way, you want to do it better. But it's finding a balance as well. So yeah.
Awesome. Yeah. Find those. I think find yourself obviously a great mentor. So shout out to Brandon here from Be Mine. But find those individuals where like you're just like, wow, those people are like, how do they do all these things, or how they've managed all those sort of things? And it probably wasn't all at once, but they were able to grow. They took 1, 2 things, did it great, then that became automated or second nature, added another thing. I have a professor like that in school, Dr. Mary Lou, and she's got like 10 high level studies going on. She does like a practice, teaches at Delaware, Arcadia, Stockton, like reviews IRBs while she's like on the treadmill talking to someone, and you're like, how is this possible? And just an amazing professor all over. And those, like, I always shoot off an email to her about things, and she's able to, in her busy life, I'm like, how you even have time to answer emails? So find those type of people, and they'll help you grow into those certain points. But yeah, awesome stuff.
Yeah.
I don't know, let's wrap up. Any closing remarks there? Any announcements? This episode will probably come out closer to February.
Yeah, so I guess by then we should have our neurodynamics course out and our slated courses for 2022. We've actually had some people reaching out about private courses, so that's awesome thing. So I'll make an announcement for anybody who maybe wants to have Jeremy and I go out to your clinic, teach your staff. I think it's always good to do that for your staff. Everyone gets on the same page. You can learn better that way because now there's some accountability. You have somebody to practice with. You have somebody to kind of hold you accountable for, implementing or not implementing what was learned. It's always easier that way when you have a group of people versus one therapist takes this course and another therapist takes another course. And you guys are, I learned it this way, I learned it that way, or this person says this and it contradicts. So I think it's always good for, getting everyone on the same page. Definitely good to get camaraderie with your staff. Having everybody in the same room for 2 days is always a way to grow the team. So we are doing that as well. Jeremy has rehab coaches that'll be up and running in 2022. And we have our mentorship program as well. So if any questions, feel free to DM us, email us, whatever.
Yes, indeed. Thanks for tuning in, everybody, and cheers.
Cheers.